All right, good afternoon, everybody. I'm gonna start so I can finish on time. Let me start with this case first. A 40-year-old male, plasmatic hypertension, non-insulin-dependent diabetes, coronary disease, presented to the hospital for nausea and vomiting. He's also endorsing abdominal pain. Pain started a day ago, 24 hours. These are his vitals: his tachy, heart rate 110, blood pressure 90/50, respiratory rate ranging 22 to 28, with normal temperature. The only thing positive in the exam is diffuse abdominal pain, and these are his labs. Sodium 132, slightly hyperkalemic 5, chloride 108, bicarb 12, BN 30, creatinine 2.4, with the CBC only showing slight anemia, hemoglobin of 11. Lactate or lactose of 12 with normal albumin. What do you guys think? Mostly for the first year fellows.
Mesenteric ischemia.
Okay.
Colitis.
So hold your thoughts. I'll be talking about extracorporeal therapy and management of drug overdose. No, that's good. I mean, so I have no disclosure, but the way I'm going to do this lecture, I'm going to talk a little bit about introduction. Different type of extracorporeal therapy, the indication of it, and most of the lecture is going to be about cases. So, as you saw, most of the cases are going to be like one slide. All the hints are going to be in it, one slide for labs, and I want you guys to tell me what do you guys think. What kind of medication or overdose it is. All right, so it's going to be a lot of interaction here. So, poisoning and drug overdose remains a common medical emergency. There's a report in 2011 that showed 2.3 million cases in the United States. 70% of them were managed at the site of incidence in a non-healthcare facility. The spectrum of agents ingested is wide, ranging from prescriptions to poverty drugs to poisoning with non-pharmacological substance and recreational drugs. In industrialized societies, the toxin agents ingested include analgesics, from acetaminophen, opioids, salicylate, antidepressants, sedatives, and antipsychotics. In the past, barbiturate was also common, but now it's less common. Data in the U.S. indicate a low mortality with only 1,995 fatalities for the 2.3 million episodes. When we're dealing with an overdose case, certain questions need to be answered to determine the need or form of extracorporeal therapy treatment. But before we go to that, what are the mainstays of management when we see something like this? So just to save time, I'll just go ahead with it. So first we have to make sure that hemodynamically supported, respiratory supported, and also to keep in mind the prevention of any other drug absorption. Any enhancement of drug elimination, does need any extra support to take the drug out of the system. So for prevention of further drugs, we need to think about oral activated charcoal, and only in specific cases, of course. Neutralization of drug toxicity, like NAC or digibindin cases. The extracorporeal therapy is one method only for achieving poison removal, either by dialysis or non-dialytic technique, which is called hemoperfusion. I'll be talking briefly about it. These enhanced techniques are only occasionally needed, with only 2,300 patients from the recorded 2.3 million required extracorporeal therapy. In that report, the treatment was the hemodialysis was predominant, with only 14 patients required recorded received hemoperfusion. So, what are different modalities of extracorporeal treatment? And Karim, do you know any different modalities for extracorporeal treatment? No. Any takers? So it's actually a lot, but here's just some of it. We go from hemodialysis or hemofiltration. Peritoneal dialysis also can be done. Any continuous renal replacement therapy, CRRT, hemoperfusion, also molecular absorbent recirculation system, MARS. Plasmapheresis is also considered, and transfusion exchange also considered a form of extracorporeal treatment. So I'm not going to be talking about details about all of these, but I'm going to... What happened? Okay. I'm not going to be talking about details, but just an idea about some of these therapies. So in general, hemodialysis, a toxin and other substance are cleared from the blood by diffusion across a semi-permeable membrane down a concentration gradient. In order for the substance to be removed, we need it to be water soluble. It has low molecular weight. It also has to be low protein binding, low volume of distribution. And all these four you're going to see me repeated again and again. So this is why we need to think about it, or to think about the drug when we decide is it dialyzable or not. Other factors that affect substance removal include membrane surface area and type. So the bigger the membrane, the better the removal of the toxins. And the blood flow rate and the dialysate flow rate, the higher the flow rate, the better the clearances.
Can you, what factors of a structure, of a protein, or of a structure make it change its volume and distribution that aren't related to its molecular weight and its protein binding?
I'm not following the question. I didn't understand the question.
So I would think of the volume distribution be related to how soluble it is.
Yeah. So
what other than its solubility affects its volume distribution?
well, is it water or lipid soluble? We got that one as well. We got like other than protein binding, or some medication that have more penetration into the tissues, and some that don't. But other than these, I'm not sure.
So the things that you mentioned on there all add up to whether it's what
volume
distribution would be.
Yeah. So in this picture, I want to show you what a semi-permeable membrane looks like. The blood comes in, and then the dialysate flow out. The dialysate comes in, so it's a counter current. And the bigger the semi-permeable membrane, the better the clearance. Also, the faster the blood and the faster the dialysate also have a better clearance. Continuous technique, any other form of CRRTs, either in CVVH and CVVHD. Blood passes through larger pores or hollow fibers, allowing the convection removal of large molecules. And the advantage of these techniques, first, of course, it can be applicable in hemodynamically unstable patients. It prolongs the duration of therapy. As we all are aware, dialysis, we can rarely do it more than 4 hours without anticoagulation. Minimize the risk of rebound effect, I'll be talking about later as well. But one of the disadvantages of this CRRTs is their lower clearance compared to hemodialysis. So if you think about it, the clearance is equal to the ultrafiltration rate. In CRRTs, they're usually no more than 4 liters an hour, or like 60 ml per minute, in our case in our sled. But in hemodialysis, it can go up to 500 ml a minute. So it can go up to 30 liters an hour. So this is just to show you about the CVH. This is what we have here. So blood comes in. These are the filters. It takes off the fluid, and basically whatever the patient's blood, or should be exactly whatever we're giving him the fluid. So the bags that we hang in, especially in the CVH, this is the bags in, and his blood should be like the toxin should be removed, or all the sodium or K or all whatever is in the bag should go back to the patients. And we have something called post-dilutional hemofiltration, but no need to talk into details about it for now. Hemoperfusion, I mentioned it earlier, but what is it? Basically, the blood passes through a cartridge containing absorbent material able to absorb the toxins. We have 3 types of sorbents: charcoal-based, synthetic resins, and anion exchange resins. In order to be removed, the toxin needs to have a binding affinity to the sorbent in the cartridge and low volume of distribution again. For the charcoal, efficiently removes molecule in the range of 1,000 to 1,500 kilodalton range, but does not remove protein-bound molecules. But resins effective in removing protein-bound and lipid-soluble molecules. But we have seen the use of hemoperfusion decline the last 20 years due to the limitation of the indication, their shelf life, and technically more difficult to perform than hemodialysis. So it's the same idea as hemodialysis. See the blood come in, but this is the cartridge, and these are all the sorbent here and just go back in. But what also, if you guys heard about the molecular absorbent recirculating system, another common name that is used is albumin dialysis. So basically, a blood purification system aimed to remove the albumin-bound toxin molecules. It consists of 3 serial extracorporeal circuits: blood circuit, albumin detoxification circuit, and hemodialysis circuit. So this is the blood. This is the blood circuit. You got the blood coming out of the patient, go to the dialyzer, and then we got all going back to the albumin circuit. And the albumin circuit, we have 2 extra circuits here with the charcoal. With a charcoal filter here, which absorb the toxins, and an ion exchange as well. Resin filter here. And if you also notice, this is the single pass or dialysis, which is like basically the albumin goes in, and another form of gradient of clearance happens, especially with the bicarb buffer, and then all this goes back to the patient. Do we still do it? Although the efficacy of MARS in the removal of protein-bound drugs, especially the thiazide, phenytoin, and theophylline, has been demonstrated in some cases. The use of it's limited by its availability, technical applicability, and high cost as well. In this slide, in this table, I'm just showing the 3 main types, but hemodialysis, hemofiltration, and hemoperfusion. And as I mentioned earlier, these stuff that we have to take into account when we're looking when we have to decide if this drug is dialyzable or not. Their solubility, it's their molecular weight, 500 Dalton, 40K Dalton, or for the hemofiltration and hemoperfusion. If I had to put in perspective, the first thing that we see after dialysis is creatinine and BUN. What's the molecular weight of them both? So the BUN ranges somewhere between, I want to say 24, and the creatinine is somewhere else around 40. So to have a better idea, anything more than that, especially if we have immunoglobulins, cannot be dialyzed with hemodialysis. Protein bound, we need it all to be low, except for hemoperfusion. And as we said, it depends on what kind of sorbent is being used. Volume of distribution, the higher the volume of distribution, the more difficult. And the endogenous clearance. What do I mean by that? I'm going to be talking about later. And the distribution time. Is it short, longer, and how long can we use this form of extracorporeal therapy?
What's distribution time?
Distribution time, basically when we have a drug that is actually going to more than one compartment. They go intracellular and stays in the blood. And once we clear it, basically we're expecting all the blood to be cleared, but we don't know exactly what's the intracellular or the other compartment of that substance is. So in the distribution time, we only have, for the hemodialysis to be effective, we need a short time for that toxin to move from the intracellular to the blood. But if it's longer, then we don't know if this will be effective or not. We're going to show you a couple of cases after this. And this slide, I'm just showing you the difference between hemodialysis and hemoperfusion. Not too much about it. This goes by diffusion, the hemodialysis, so it's only molecules. And you can see the dialysate, that's what we use, and this is what we mainly use here. And we see the hemofiltration, and we need filtration, is water and molecules go. So basically it's a pressure gradient. Again, I'm stressing the factors that are affecting the toxin removal, especially by hemodialysis. And why am I saying about hemodialysis? Because that's the most common form used, and it's also most common available. I mean, that's what most hospitals have available. So molecular weight, water solubility, degree of protein binding, and significance of dialytic toxin removal relative to the endogenous route of clearance. So if we have a medication that is metabolized by the liver and cleared by the kidney, but we have a renal failure, maybe we need to consider dialysis. And the volume of distribution, we need to keep that in mind. And the degree of solute compartmentalization. And this is why I say between different compartments as well. And in this slide, I'm showing, what do I mean by that? So if we have a dialyzer here, and let's say this is just an example of the proximal compartment, just the blood, and we can see only blood goes to the dialyzer, but we don't know exactly what's going on in the other remote compartment, the intracellular. So if the equilibration between these two is fast, hemodialysis will be effective. But if it's slow, and after we clear all of the proximal compartment, it will take time for the toxins or whatever substance goes from the remote compartment to the proximal compartment to equalize, so we might have what we call rebound. So we should know this, the criteria for considering extracorporeal therapy for poisoning. Any takers from the first years? Well, you're going to be attending, we don't count. Wing, anything? I'm going to be picking everyone, so. Karim already hates me. What is it? Okay, that's one. The blood levels, of course. If there's a threshold of toxicity, we need to know it. The serious clinical manifestation despite optimal support. And delayed action potential. There are other toxins that have delayed action potential, like ethylene glycol, methanol. And as you mentioned, severe acidosis. And if we have an impaired endogenous growth, like liver failure or renal failure. In this slide, I'm just showing you the list of drugs that can be treated by either hemodialysis, hemofiltration, hemoperfusion. And we see that dialysis have a wide range of medication that can, or toxins that can be cleared by hemofiltration, some hemoperfusion, also few. All right, back to the case. Who answered the question? Who said mesenteric ischemia? Huh? Mo? All right. I'll read it again. 40-year-old male, hypertensive, diabetic, type 2 coronary disease, presented to the hospital for nausea and vomiting. He was also endorsing abdominal pain. The pain started 24 hours ago. These are his vitals: tachy 110, hypotensive 9/50, tachypneic 22 to 28, normal temperature. The only positive thing in his exam is diffuse abdominal pain. And these are his labs. As we see, have severe acidosis, AKI, a little bit of anemia, lactate of 12, and normal albumin.
You still like your answer.
These are his medication list: Lisinopril, aspirin, metformin, and carvedilol. So it's metformin. So the molecular weight of metformin is 166 Dalton. It is a non-protein bound. It's excreted by the kidney, but it also can cause renal failure. And it can be cleared by, as you saw, hemodialysis or hemofiltration because of the low molecular weight and non-protein bound. But metformin usually is excreted much better than creatinine in a normal situation because it's excreted by the glomerular and the tubular secretion. When do we stop dialysis for these patients? When the lactate usually reaches 3 or less, or for the pH more than 7.35. This could be another case. So all the cases going to be one slide, and the labs on a different slide. So it shouldn't be a problem really. So we're going to have quite a few cases here. 36-year-old female, non-pregnant, presented to the ED via EMS after a family member called stating that the patient was confused. In the ED, the patient was found to have a slurry speech, weak pulses, and labored breathing. Past medical history: migraine, epilepsy, and hypertension. Vitals: heart rate of 60, respiratory of 12, blood pressure 100/50, and temperature of 37. These are the labs. Sodium 142, K 4.2, chloride 104, bicarb 23, 23 BUN, creatinine 1.04, CBC, a little bit anemic 12.7 with a hematocrit 32, lactate of 1, and normal albumin. What is your differential? Okay, what is the drug that she took? Make that easy. So in every case, they are only giving the hints that need to be known. So she's confused, slurry speech, weak pulses, labor bleeding. And she has a history of epilepsy. I think I gave it away. Any takers? 2020? Close enough. It's barbiturate. So it has low volume of distribution as well. Molecular weight of 232. It is hepatically metabolized and binds readily to charcoal. It can be managed medically by administration of activated charcoal and urine alkalization by giving sodium bicarb. But when should we consider basically the dialysis or the extracorporeal therapy if they're hypotensive, which the patient was, respiratory distress, or deep prolonged coma? So extracorporeal therapy depends on the severity of the toxin and the response for the treatment rather than the blood levels. So we don't need to check that. And in this situation, we can use either hemodialysis or hemofiltration. Another case. 53, and by the way, these are mostly, we have a couple of C questions, we have ASN questions, we get case reports. So, I didn't make them up. 53-year-old male presented to the ED for difficulty in breathing and confusion. Last seen normal was 2 hours ago. Unable to obtain history, sorry for the typo, from the patient. No family member available. In the ED, the patient had a witness seizure that was grand mal in nature, lasting for 1 minute, and responded to lorazepam. These are the vitals. Heart rate 40, heart rate 26, blood pressure 80/40, temperature 36.8, and the only positive thing in exam is he's wheezing and a call to touch. These are the labs. Sodium 138, Kf 3.8, chloride 108, 22 of bicarb, 32 BUN, creatinine 1.2, CBC within normal. Lactate of 2, albumin of 4, and glucose of 30. What do you guys think? Beta block. So it can present within 2 hours of ingestion. And it can cause cardiogenic shock in severe cases. Bradycardia can be treated by atropine, and the bronchospasm can be treated initially with high dose of nebulized albuterol. Activated charcoal can be administered, but it has to be within the first 2 hours. The extracorporeal removal is effective only in hydrophilic medications, so are minimally protein-bound drugs. So not all beta blockers can be treated by extracorporeal therapy. An example: atenolol, sotalol, nadolol, and butylol. I've only seen atenolol so far. But the more common that we use, the propranolol, timolol, and metoprolol, it cannot be removed by dialysis. Intermittent HD is recommended in hemodynamically stable patients. CRT is considered in unstable patients, either form of CVH or CVHD. It's rarely needed for beta blockers to require a form of dialysis, only if they have improper response for the maximal medical therapy. And if we decide, and we only have a few days for CVH, but that's what they're recommending. Another case. 65-year-old male found in a state of clouded consciousness of unknown duration. In the ED, GCS was 9. Naloxone and thiamine with no change in clinical picture. CT had done that showed no acute injury. Unknown past medical history. Heart rate 120 is an AFib. Blood pressure 94/50, respiratory 22, temperature 37.2. Later in his exam, GCS went into 6. They intubated him for airway protection. And these are the labs. Sodium of 142, Kf 3.2, bicarb of 115. I'm sorry, chloride 115, bicarb 26, and BN of 20, creatinine 0.89, normal CBC. Lactate 1.2, albumin of 4, glucose of 92. What do you guys think? You guys need to talk. That's fine. Well, you're Arab. That's fine. That's different. All right. Any more info you guys need?
Can you go back to the story?
All right. What if I told you that serum osmolality is 324? His serum osmolality 324. He's not acidotic. But if you look, 26 plus 115, that's 141. It's only 142. So if I have, just for the sake of it, I have to calculate his anion gap, it's 1. No? What toxins or diseases can cause low anion gap? Because 1 is low, right? Normal is 8 to 10. All right. Somebody ordered lithium level was 14.5. So it is lithium. With a molecular weight of 74 Dalton. It has a low body distribution and non-protein bound as well. It can cause arrhythmias, hypotension, confusion, coma, or seizure as well. HD recommended if the serum level is more than 4 or more than 2.5 in patient with CNS manifestation. Lithium equilibrates relatively slow between the extracellular and intracellular compartment. So a rebound increase in serum levels of lithium follow HD. So once we finish HD, we check the blood level immediately is going to be low. But if we check it after a specific number of hours, in this case 6, it might have a rebound. So a level should be checked 6 hours after completion of HD to guide further therapy. Clearance of lithium by HD is actually much better by the kidneys, and the reason is that because in the kidney there's a reabsorption in the proximal tubules for the lithium. But if we check the level after 6 hours, you might make a case either that you want to start them with HD or put them in any form of CRRT. In this hospital, we do it very often for ammonia patient, hyperammonia patient, put HD at night, put in form of CRRT. So we need to keep that in mind. When do we stop dialysis? Either with lithium less than 1 or clinically improved. All right, another case. 23-year-old female, main complaints include nausea, vomiting, gastric pain, and diarrhea. She's also endorsing dizziness and blurry vision. On review of symptoms, she only complains of headaches, on and off. While in the ED, she developed respiratory distress, and X-ray reveals pulmonary edema. Unknown past medical history. She's tachycardic 110, tachypneic 30, blood pressure 146/90, and temperature of 39. On the exam, she is sweating, and she is in respiratory distress. These are the labs. 137 of sodium, hypokalemic 3.1, chloride of 104, acidotic bicarb of 12, BN 16, creatinine 0.7, a little bit anemic 11.2 for the hemoglobin. Lactate 1.4, albumin 3.7, glucose 72 with the ABG, pH of 7.5, PCO2 of 13, PO2 of 81, bicarb of 10. What do you guys think? Labs? Too much Narcan. Okay.
Isn't this respiratory alkalosis with salicylic toxicity?
So, I mean, she's acidotic, but alkalemic.
Yeah.
Okay. So,
Respiratory alkalosis.
so what is that?
Salicylate.
Salicylate. Salicylate. So at a therapeutic level, more than 90% of this medication is protein bound. Metabolized in the liver and excreted by the kidneys, with a T-half ranging from 2 hours to 30 hours. Moderate toxicity occurs within the levels of 50, and when we have a toxicity, the protein bound decreases 50 to 75% because of the nature of the competitive receptors binding. An enteric-coated salicylate may delay peak levels for up to 36 hours. Lavage should be attempted up to 12 hours after ingestion if the airway is protected, and activated charcoal should be administered orally. Dialysis should be started when the serum level exceeds 70, or when the clinical situation deteriorates, altered mental status, respiratory failure, severe acidosis, pulmonary edema, and renal failure. Increased salicylate tissue penetration and toxicity can occur with only small decrease in the blood pH as a result of the increased concentration of the non-ionized salicylate. We can consider actually giving sodium bicarbonate in this situation to decrease the tissue penetration and facilitate the excretion by the kidneys, or also, if needed, by dialysis. We need to check the levels 2 hours after dialysis for possibility of rebounding, which might require another hemodialysis treatment. When do we stop dialysis? Either when levels are less than 19, or if the levels are not available, we can stop it 6 hours later and continue monitoring the patient. Another case, 37-year-old male, unresponsive at home. On arrival to the ED, his GCS was 4 with cosmal respiration. He was intubated for airway protection. Past medical history, depression. Heart rate 82, respiratory rate 16, blood pressure 126/84, temperature 37.1. His exam, the only thing is positive is his cosmal respiration, and with the GCS of 4. These are the labs. We got sodium 143, potassium 4.9, chloride 110, bicarb of 8, BUN of 38, creatinine 1.5, CBC a little bit anemic as well, lactate of 30, albumin 3.9, glucose of 232, with an ABG of 6.8 pH, 37 PCO2, PO2 115, and bicarb of 5.5. What do you guys think? Any takers? Huh? TCA? Okay. Any other info you'd like to know? You would like to know serum osmolality? Okay. Serum osmolality 828. Ethylene glycol level of 1254. When you have severe acidosis, we have to keep in mind that it's worth checking serum osmolality. We need to keep it part of our knee-jerk reflexes, if I may say. So ethylene glycol, it's a compound used in an antifreeze and windshield washer solutions, converted by alcohol dehydrogenase to glycolate and oxalate, which causes renal failure and pulmonary and cerebral edema. Inhibition of the alcohol dehydrogenase achieved by either ethanol or fomepizole. Hemodialysis should be started when signs and symptoms of severe toxicity are present, either deteriorating vital signs, severe metabolic acidosis, AKI, pulmonary or cerebral edema, or when the serum level exceeds 0.5 gram per liter. For the fomepizole, do you guys know how it's administered? Have any one of you guys ordered it by any chance? So the way it is, it goes actually in a couple of doses. First, we have to load the patient, 50 milligram per kg IV, and then 10 milligram per kg every 12 hours, total of 4 doses. And after that, 15 milligram per kg for another 12 hours until the acidosis resolves, or the serum concentration drops below 20 or 10 in the case of end organ damage. But we can consider giving thiamine and pyridoxine in patients with poor nutritional status. And the reason for that, these two are water-soluble B-complex vitamins that act as metabolic cofactors in the metabolism of ethylene glycol. So they actually promote the transformation of glycosidic acid to non-toxic metabolites. So it can help metabolize this glycol. 30-year-old male working at a pharmaceutical company presented to the ED for vomiting. He's complaining of blurry vision and restlessness. Later, patient developed respiratory distress, which required intubation. Past medical history is negative for any chronic diseases. Heart rate 112, respiratory rate of 22, blood pressure 107/76, with temperature of 37.8. Nothing abnormal in the exam. CTH show hypodensity in the bilateral basal ganglia. These are the labs. Sodium 135, K4.2, chloride 106, bicarb of 8, BN 42 with a creatinine 1.9, hemoglobin 15.1, with a lactate of 14, albumin 4, glucose 198. What do you guys think? Anything you need to know? Yes, severe acidosis. I need to know the serum osmolality. It was 320 in this case. And if you calculate it, the calculated serum osmolality is 298. So there is a gap. I'll go back to the case. He has blurry vision. I think that's the key. Huh? Methanol. So for methanol, it is again metabolized by alcohol dehydrogenase to formaldehyde, and then also get metabolized or dehydrogenase to formic acid. The inhibition of the alcohol dehydrogenase is achieved by administering again ethanol and or fimoprazole. The criteria for dialysis is severe acidosis, visual impairment, renal failure, electrolyte disturbance, or plasma methanol level of more than 0.05. However, the hemodialysis does not substantially enhance the endogenous clearance of formate. And we also can consider give folate. And the reason that we can consider give folate, when they looked at actually rat and monkeys, they found that if you give methanol to rats, they don't develop any toxicity. And the reason for that, they believe that the folate can cause marked decrease in the blood formate accumulation. So basically, it just increase the metabolism of the formate and prevent metabolic acidosis. So you're going to find this sometimes recommended. Consider giving folate. For optimal clearance, the dialyzer should have a large surface area, and the blood flow should be greater than 300. So just to let you guys know, our sled machines are 60 cc per minute. I'm not saying that it cannot be ordered, but for 300 we need at least hemodialysis or CVVH. Bicarbonate buffers should be used, and serum concentration of ethylene glycol and methanol should be measured 2 hours after cessation of the treatment to take into account again the rebound. We continue with the treatment until the pH has normalized and the concentration of ethylene glycol or the methanol again below 0.25. Another case, 30-year-old male presented to the hospital after his wife heard him fall from his bed. At this time, she found him unarousable. The ED, he was confused, combative with GCSF. He was intubated due to an apneic episode and airway protection. He's bipolar and hypertensive, heart rate 96, respiratory 12 to 14, blood pressure 138/90, temperature 37.6, obtunded, but withdrawal extremities to painful stimuli. CT head is negative for acute changes. These are the labs. He's hypernatremic 152, K4.4, chloride 112, bicarb of 17, 42 BUN 1.9 creatinine, nothing significant in the CBC, lactate of 14, albumin of 4, again glucose 198. What do you guys think? Somebody ordered ammonia and it's 176. And somebody ordered serum osmolality again, it's 321. One medication can cause hypernatremia, hyperammonemia with an osmolar gap, and in situation hypocalcemia as well.
Does he have an osmolar gap?
He does.
Sodium
152. 152.
300 right there.
Is that? I calculate. Yep, you're right. I apologize. It's not. I apologize. You're right. Valproic acid level 998 microgram. So the valproic acid. It has a low molecular weight as well, 144 Dalton, 90% protein bound with low volume of distribution, mainly metabolized in the liver. Signs of toxicity range from lethargy to coma. In addition, it can cause hypothermia, hypotension, hypernatremia, hypocalcemia, metabolic acidosis, and hepatotoxicity. The indication of dialysis or hemoperfusion is a case of refractory hemodynamic instability or severe acidosis. It's poorly cleared despite the low molecular weight and low volume distribution as a result of its high degree of protein bound. So, higher serum levels above 100, and the valproic protein binding site becomes saturated, resulting in unbound free drug. So despite the number of case report of detailing the extracorporeal valproate, there is no clear-cut evidence that it will improve the clinical outcome. And if you decide to dialyze this patient, when do we stop? When there's a clinical improvement or the levels between 50 to 100. Another case. 52-year-old male homeless brought to the ED by EMS after being found unresponsive by his friend. The patient is known being alcoholic, but his friend stated that he has been out of money for the past 1 week. Non-insulin dependent diabetes and alcohol abuse in his past medical history. Vitals, heart rate of 80, respiratory rate of 12, blood pressure of 100/70, temperature of 36. An exam, has fruity odor smell, traces of edema, minimally responsive and disoriented with mild nystagmus. Chest X-ray is clear. CT had mild ventricular atrophy. These are the labs. Hyponatremic 130, KF4, chloride 100, bicarb of 24, BN of 24, creatinine 1.4. Not much to see in the CBC. Lactate 1.5, albumin of 4, glucose of 240, ABG showing pH of 7.4, PCO2 35, PO2 of 80, and bicarb of 23. What did he take? Okay. 310 is serum osmolality, and calculated is 282. It's positive for ketones in serum and urine. It is isopropyl alcohol. It's a compound found in rubbing alcohol and disinfectant, also used in the manufacture of acetone and glycerin. Rapidly absorbed with peak effect seen within 1 to 2 hours. Its minimum toxic dose is 100 ml, and it can be either done either through oral or dermal absorption, actually. Unlike ethylene glycol methanol, most of the toxin effects are due to the parent compound itself. And the key diagnosis, as we just saw, of course, the osmolar gap with absent metabolic acidosis. So it's metabolized by dehydrogenase to acetone, and acetone accounts for the high ketones formation, but not a true acid, so explaining the absence of acidosis in this case. But it does count for the serum osmolality, explaining the high gap. Clinical signs of intoxication include GI symptoms, confusion, stupor, and coma. Severe intoxication can cause hypotension due to cardiac depression and vasodilation. And hypotension is usually the strongest predictor of mortality in these cases. So it's not, unlike ethanol and methanol, inhibition of alcohol dehydrogenase is not indicated because the metabolized compound is not toxic. Hemodialysis is indicated for levels greater than 4, and significant CNS depression, renal failure, or hypotension. So we talked about the things that we know that dialysis can work on, but there's other medications that we might encounter that extracorporeal therapy may be a possibility. The data out there is still questioning it. First is is carbamazepine. It's a highly protein bond with a molecular of 236, metabolized in the liver and eliminated by the kidney with the elimination half-life of 2 to 6 days. Although supportive care is usually sufficient, elimination can be achieved by either hemodialysis or hemoperfusion. So what they actually recommend for carbamazepine, they consider this form of treatment when you have unstable cardiac status epilepticus patient, or refractory bowel hypomotility. Diltiazem results in marked hypotension with mortality rate as high as 10%. 80% are protein bound with high volume distribution. Due to that, hemodialysis or hemofiltration is not suitable. MARS, or the albumin dialysis, was described recently as being effective with reaching half-life of approximately 16 hours. And we have this study, or the case report, about albumin dialysis for treating for severe diltiazem toxicity. It was just only a case report, and it was in 2008. Phenytoin, 90% metabolized, 90% protein bound, metabolized in the liver and eliminated by the kidney. The median half-life is 24, ranging from 24 hours, but ranging from 7 to 42 hours, anywhere between. It has narrow therapeutic range. No evidence that enhanced elimination is beneficial, but phenytoin was described to be effectively removed by MARS, reaching half-life of approximately 6 hours. Mushrooms. Fatalities due to mushrooms poisoning are rare, less than 1%. Most fatalities are caused by the cyclopeptide-containing species from the genera of Amanita, Clarine, no matter how many times I try to read it, and Leopada, and are the results of late-onset hepatorenal failure. The cyclopeptides are divided into 3 classes of peptide: amatoxins, phytotoxins, and virotoxins. The amatoxins may be enterohepatically recirculated and interact with the RNA polymerase II, leading to liver cell necrosis by inhibition of the protein synthesis. So theoretically, it should be possible to eliminate them by hemoperfusion, as they have low molecular weight, high affinity for charcoal polymers. However, the utility of the extracorporeal therapy is questioned given the serum concentration and the fact that their intracellular aminotoxins concentration reaches peak within 1 hour of ingestion. The success of MARS in the treatment of mushroom poisoning may be contributed to its liver support function as a bridge to liver cell regeneration or liver transplant. Sounds like ECMO, doesn't it? And this is also basically a case report, or a study that looked at extracorporeal albumin dialysis in patients with mushroom poisoning, which show also beneficial, but as I mentioned earlier, it just decreased the half-life of it. Any questions? Great, thank you.
على الوقت